Hello, my name is Joe Sestino, and I've been asked to give you a lecture on cardiac embryology today. A little bit about myself. I helped start the program at Emory. I was the program director at the Medical University of South Carolina for 20 years. Before that, I was chief perfusionist at New York at two large hospitals. I was perfusionist of the year in 2015, and I received the Gibbon Award last year at AMSEC. I have 45 years of experience as a perfusionist. The last 10 years or so doing mostly pediatric perfusion. Before I've done pediatric perfusion my whole career, but in the last 10 years before I retired, I did mostly pediatric perfusion. So today we're going to be talking about the embryonic stages of fetal development, the etiology of congenital heart disease, and some of the major developments of the heart as it develops in the embryo and timing in the embryo. Next week we'll talk about the vascular system, review fetal circulation, and discuss the relevance of fetal development to cardiopulmonary bypass. So embryology is important because it leads to congenital heart disease, and congenital heart disease is the #1 congenital abnormality. It affects almost 1 in 100 births, approximately 1%, and it's a major cause of prenatal death. And on the right-hand side, you can see the percent of congenital heart defects, with ventricular septal defect being most common. But we see a lot of atrial septal defects, patent ductus, pulmonary stenosis. At MUSC, we did see a lot of tetralogy of Fallot and some transpositions. A lot of hypoplastic left heart syndromes. So incidence of congenital heart disease is very high in newborns, and that's why it's so important to have good cardiac surgical programs that can repair. Most of these defects can be repaired today. When I first started, there were a number of defects that could not be repaired, like hypoplastic left heart syndrome. They used to call that single ventricle, and there was no operation for that until the 1980s, until prostaglandin was discovered. This gives you a little bit of background on when congenital heart disease was first identified in the 1400s. They noticed dextrocardia, or reversing of the heart, mirror imaging of the heart. 16th century, patent ductus, foramen ovale, and then in the 1800s, Fallot described the 4 defects in tetralogy of Fallot. In the United States, pediatric cardiology first got really developed after the operation to help patients with congenital tetralogy of Fallot at Johns Hopkins University, and there was a cardiologist there, Helen Taussig. You probably heard of the Blalock-Taussig shunt. She graduated from Hopkins, but she didn't have. She became deaf and relied on lip reading and hearing aids for the rest of her career. Most people don't know that about her. But she was able to. She was very active in developing the field of pediatric cardiology, and she was helped to make diagnoses that were more sophisticated diagnoses than were made before that time. And she, let me just remove this camera for a minute. Oh, I can't do it now. Can't move it. Anyway, sorry about that, but she helped to make diagnoses by other ways rather than auscultation because she couldn't hear. Some of the surgical history for congenital heart defects. In 1939 was the first PDA closure, which is outside of the heart. The BT shunt that I talked about just before at Johns Hopkins was done in 1945 to increase pulmonary blood flow in tetralogy patients. In 1950, Bigelow did experiments on dogs and showed that it could undergo circulatory arrest at low temperatures without brain damage. And that led to some of the operations using surface cooling and closure of ASDs without cardiopulmonary bypass. Of course, Gibbon did the first successful bypass, 1953, May 6th, closed an ASD with it was a very difficult case, and the patient almost died, and he lost the other three cases that he did. The other three patients that he did died, so he stopped doing heart surgery. So if you get a chance to read about that operation, it's really amazing. In 1954, Mustard attempted doing an arterial switch using monkey lungs as an oxygenator, and Lilly Hyde did cross circulation in 1955, which really showed that congenital heart defects could be fixed, and he had a very high success rate. Kirkland did first large series at Mayo Clinic with cardiopulmonary bypass, and then in the 60s, Rastelli started using valve conduits, which allowed operations with single ventricles, like truncus arteriosus, or operations with single ventricles to occur because they needed to have conduits to get blood from the right ventricle to the pulmonary artery. In the last 20 years, operations of patients have gotten smaller. Instead of having two operations, instead of having a palliation operation, they would, like for instance, in patients with VSDs, they used to take a band and put it around the pulmonary artery to keep the lungs from getting flooded and overperfused. And then 2 or 3 years later, they would close the VSD. So today, all these operations can be done on neonates, and there's less palliative procedures, so the patients really need to have one surgery instead of two. And we're doing more complex surgery in the early stages of life, in the first few months of life. Some patients do get stage procedures. They're younger. Their first operation is usually a neonate, and then they'll have another operation down the road. And so we have to deal with more reoperation patients, redo operations, which, you know, opening the chest on a redo is a lot more difficult. But altogether, there's only about 20,000 operations a year in the United States. And, you know, that's pretty small compared to the 300,000 or so procedures done in adults. 56% of all open heart procedures are performed in children less than 1 year of age, and about 20% during the first month of life. So the trend is that patients are getting smaller and smaller, and that there's less palliative operations, and patients are getting primary repairs. And this is from a little bit older survey from Pediatric Perfusion, but just shows the change in patient age. This is 2004, and you can see this. The black line is the patients less than 1 month of age, and over the years from 1989 to 2004, the number of patients getting operated on the first month of life keeps going up, and the first year of life keeps going up. All right, so getting back to fetal development, we're just going to identify the trimesters of pregnancy. First trimester is conception to 12 weeks. Second trimester is 13 weeks to 27 weeks, and the third trimester is 28 weeks to 40 weeks. So it's a little confusing how they count the weeks of pregnancy. It is usually counted from the first day of the woman's last period, not the day of conception. So you know the date of conception is usually around 2 weeks after the woman's last period. So actually, the first 2 weeks of pregnancy don't really exist. When the fertilization occurs, pregnancy is already 2 weeks later. So just to go review a little bit of fertilization. If a sperm permeates the egg, fertilization results. There are tiny hair-like cilia lining the fallopian tube that propel the fertilized egg, called the zygote, through the tube towards the uterus. The cells of the zygote divide repeatedly as the zygote moves down the fallopian tube to the uterus, and then the zygote enters the uterus in 3 to 5 days after fertilization. In the uterus, cells continue to divide, becoming a hollow ball of cells called a blastocyst. The blastocyst implants in the wall of the uterus about 6 days after fertilization. So just to give you an overall view of fetal development, we just talked about attaching, the blastocyst attaches to the uterus, and then it's finally embedded in the uterus with some connections for blood flow. The heart begins to form at day 16, it begins to pump day 20, so these are days after fertilization. Day 21, the aorta and the veins begin to form about the same time that the heart starts to pump. Then heart folding occurs, and then cardiac septation. So the numbers that are important are when the heart begins to pump, when the aorta and veins begin to form, when the heart starts folding, and cardiac septation. Aortic arch development occurs around the same time as cardiac septation. So you can see that defects can occur at any of these stages when the aorta and the veins begin to form, when the heart starts folding, and cardiac septation. These things all, and aortic arch development. These early days are very, very important in cardiac formation. Overall, weeks 5 to 10, that's weeks after a pregnancy, the organs begin to form. So that's when it's critical that exposure to certain substances don't occur during pregnancy, because they can cause defects in other organs in the body. Okay, about 6 days after fertilization, the blastocyst attaches to the lining of the uterus, usually near the top, and this is called implantation, which is completed by day 9 or 10. The wall of the blastocyst is 1 cell thick, except for one area where there is 3 to 4 cells thick. The inner cells in the thickened area develop into the embryo, and the outer cells bury into the wall of the uterus and develop into the placenta. The placenta produces several hormones that help maintain pregnancy. For example, the placenta produces chorionic gonadotropin, which prevents the ovaries from releasing eggs and stimulates the ovaries to produce estrogen and progesterone. The placenta also carries oxygen and nutrients from the mother to the fetus, and waste materials from the fetus to the mother. Some of the cells from the placenta develop into an outer layer of membranes around the developing blastocyst. Other cells develop into an inner layer of membranes, which form the amniotic sac. When the amniotic sac is formed by about day 10 to 12, the blastocyst is considered an embryo. The amniotic sac fills with clear liquid, amniotic fluid of course, and expands to envelop the developing embryo, which floats within it. After 8 weeks of pregnancy, the placenta and fetus have been developing for 6 weeks. The placenta forms tiny hair-like projections that extend into the wall of the uterus. Blood vessels from the embryo, which pass through the umbilical cord to the placenta, develop in the villi. A thin membrane separates the embryo's blood in the villi from the mother's blood that flows through the space surrounding the villi. This arrangement does the following. It allows materials to be exchanged between the blood of the mother and that of the embryo, prevents the mother's immune system from attacking the embryo, because the mother's antibodies are too large to pass through the membrane, and the embryo floats in the amniotic fluid, which is contained in the amniotic sac. The amniotic fluid provides a space in which the embryo can grow freely, protects the embryo from injury, and the embryonic disc is made of 3 layers: the ectoderm, the mesoderm, and the endoderm. From weeks 2 to 4, the embryo develops within the amniotic sac. This is the stage where most of the internal organs and external body structures develop. Most organs form about 3 weeks after fertilization, which equals 5 weeks of gestation, counting from the beginning of the last period. The embryo elongates, first suggesting a human shape. Shortly thereafter, that will become the brain, and the spinal cord begins to develop. The heart and major blood vessels develop earlier by day 16. The heart begins to pump by day 20, and the first red blood cells appear the next day. Blood vessels continue to develop in the embryo and the placenta. Almost all organs are formed by 10 weeks of fertilization. This equals 12 weeks of pregnancy. The exceptions are the brain and the spinal cord will continue to form and develop throughout pregnancy. Most malformations occur during the period when the organs are forming. I mentioned that before. During this period, the embryo is most vulnerable to the effects of drugs, radiation, viruses. Therefore, a pregnant woman should not be given any live virus vaccinations or take any drugs during this period unless they are considered essential to protect her health. You can see the size of the embryo, different periods from 8 to 12 weeks when the organs are developing. So I don't know if you're familiar with the word teratology. Teratology is the science of the causes, development, description, and classification of congenital malformations. The exact cause of congenital malformations is not really known. As I said before, there is some hereditary connection in some congenital heart disease. For instance, congenital heart disease in one family member increases the likelihood in another family member. Only 15% of congenital heart cases have a determined or a genetic cause that can be linked, and about 30% of cases are associated with environmental factors such as temperature, radiation, noise, medicines, biological factors such as viruses, bacteria, and parasites. And we're going to go into this a little bit more detail now. Some of the causes of congenital heart disease. One thing that you're going to, from a genetic point of view, there are two common genetic syndromes associated with cardiac defects. There are a few others on top, but these are the two main ones. One is Down syndrome, or otherwise known as trisomy 21, and it's the most common chromosomal syndrome, and it's characterized by developmental delay, congenital heart disease, gastrointestinal malformations, and facial abnormalities. The prevalence of congenital heart disease and Down syndrome is about 50%, and the types there include using AV canal, complete AV canal, atrial septal defects, VSD, and tetralogy of flow are the most common defects. So about 50% of children with Down syndrome have congenital heart disease. Another syndrome that's associated with cardiac defects is DiGeorge syndrome, which has a number of names. It's the 22q11.2 deletion syndrome. Some people call it velocardiofacial syndrome because there are so many different defects, and there's a very, very wide range of defects associated with DiGeorge syndrome. Some are mild to some are very severe. Most patients with congenital heart disease, most patients that have this syndrome have conotruncal heart defects due to impaired development of the cardiac outflow tract, including the aortic arch, tetralogy of Fallot, pulmonary artery stenosis, truncus arteriosus, interrupted aortic arch, right side aortic arch, abnormal branching of the subclavian artery. Some patients have isolated VSDs and septal defects. So there's a whole range of defects associated with this DiGeorge syndrome, but mostly has to do with the aortic arch or pulmonary artery outflow tract, truncus arteriosus. So you should be familiar with that. And these patients also require special treatment because they don't have, um, they're missing a thymus, which controls calcium in their body, and you're going to learn about it when you learn about the particular defects, but there are some perfusion considerations that you need to make for these patients. So other things that can contribute to congenital heart disease: heavy metal exposure, um, carbon monoxide, sulfur dioxide, nitric oxide have been implicated in development of congenital heart disease. Air pollution, as you can see, proximity to high traffic areas, um, and air pollution with very small particulate matter have been associated with congenital heart disease. Hypoplastic left heart syndrome and coarctation aorta have been shown to exhibit seasonality. Peak birth months have been noted in the summer months for hypoplastic left heart syndrome, and April to May for coarctation of the aorta. Some other studies have shown bimodal season peaks for coarctation from September to November and January to March. And there's also geographical clustering and variation of congenital heart disease in different areas of the country, and that's affected by environmental factors, nutrition, UV light, viral infections as possible etiologies. Medications that the mother is taking has been investigated as potential causes of congenital heart disease. These include, as you can see, antihypertensives, antibiotics, insulin, fertility drugs, NSAIDs, anticonvulsants, antidepressants, and other types of psychotropic medication. Although moderate associations have been found, the results have been largely inconsistent and non-reproducible. So anyway, there's a lot of things that can potentially cause congenital heart disease that we still don't have the answer to. Alcohol and drugs have been widely studied as potential causal factors for congenital heart disease. Some of the literature has not been consistent, and most of the positive associations have been moderate. But dose-response relationships between alcohol, tobacco, marijuana, especially when both parents smoke, highlight the importance of measuring the totality of these types of prenatal exposure, and rather than individual exposures. So it can be a combination of exposures from both parents. Obesity, diabetes, hypertension, thyroid disorders, metabolic issues such as hyperlipidemia have been implicated in incidence of congenital heart disease. And then maternal obesity has a dose-response relationship with congenital heart disease. Infection in the mother is also a risk for congenital heart disease, and the two of the most common, rubella virus, which is German measles, has an odds ratio of 3.49, which means that it's 3.5 times more likely to have congenital heart disease if the mother is exposed to rubella, and the same thing with cardiomegalovirus, of almost 4 times greater incidence of congenital heart disease if you're exposed to cytomegalovirus. And the rubella infection is most severe when the pregnant person is infected early pregnancy, especially the first 12 weeks. The defects noted with exposure to rubella is patent ductus, pulmonary artery stenosis, ventricular septal defects, and atrial septal defects, and exposure to cytomegalovirus, or CMV, has an increased risk of tetralogy of Fallot. So the vaccine against rubella is about 97% effective in preventing rubella. Anyone who's not vaccinated against rubella is at risk of getting the disease, and it's highly infectious and can spread easily between unvaccinated people. The first 12 weeks, up to 85% of babies born to mothers infected during this time have congenital defects, including congenital heart disease. And between 13 and 16 weeks, 50% of the babies born infected during this time have congenital defects, and the second half of in the second half of the second trimester, it goes down to about 25%. So the risk is really in the first 12 weeks, and it can be easily prevented by taking the rubella vaccine. Now, factors related to the father, paternal occupational exposures such as metal, jewelry manufacturing, welding, lead soldering, paint stripping, exposure to ionizing radiation, medication use, tobacco, marijuana, and wine use have been shown associations with this, with increased congenital heart disease. One thing that we need to be concerned about is waste anesthetic gases, because we work in the operating room and there is a lot of potential exposure to anesthetic gases. When I first started, we didn't scavenge anesthetic gases, and because the perfusionist sits on the floor and anesthetic gases are heavier than air, the concentration of anesthetic gases is higher on the floor level than above, higher up in the room. So some studies have found exposure to large amount of anesthetic gases reduces fertility in both men and women and increase the risk of miscarriage in pregnant people. And female anesthesiologists and spouses of male anesthesiologists had a higher risk for first trimester miscarriage than the general population in one study. And nitric oxide has also been associated with reproductive risks, including miscarriage, reduced fertility, and congenital anomalies. So it's very important that we have a lot of room air exchanges that occur in the operating room today that we didn't have earlier. So the air is replaced constantly, and also we do scavenge anesthetic gases. And it's really important that we scavenge gas come out of the oxygenator, because most of it doesn't get absorbed by the patient. Now, most of the anesthesia systems have rebreathing systems, so they don't waste the anesthetic gas that the patient exhales. But our system, we don't reuse that anesthetic gas. It comes out the exhaust ports of the oxygenator, so we need to make sure that we scavenge that anesthetic gas out of the room. This is from Vanderbilt University, where they talk about the importance of scavenging waste anesthetic gases. Halogenated inhalation gases such as isoflurane, sevoflurane pose a risk of spontaneous abortion, and fetal malformations. Most of the data comes from studies of older gases such as halothane. We don't use halothane anymore, but that's what I used the first 20 years that I did perfusion. New gases have not found any adverse effects on fertility. So we may have to make sure that we use waste anesthesia gas scavenging and make sure it's working. Anesthesiologist has to make sure they have a good face seal during induction so gas is not leaking out. Turn off the gas when not in use. Maintain the gas source away from your personal breathing zone. Ensure the gas exchange in the room is adequate. And they say use a double mask for gas-induced child anesthesia. And then there's a whole site for working while pregnant in order to prevent exposure. So, as we said before, the weeks that are most important to prevent this exposure is weeks 3 to 10 when organs are developing. And to prevent congenital heart disease, make sure that you're vaccinated against rubella and flu. Avoid alcohol or taking medication. They recommend taking folic acid to help lower risk of giving birth to a child with congenital heart disease. Check with your doctor or pharmacist before you take any medicine during pregnancy. Avoid contact with people who have an infection. If you have diabetes, make sure that it's controlled, and avoid exposure to organic solvents, such as those used in dry cleaning, paint thinners, and nail polish remover. So we'll get back to cardiac development. We talked about the embryo implanting into the uterus, and within the embryo or heart, you can see this heart tube starts to form right here. Let's see if we can get that right there. There's a heart tube starting to form. You have the amniotic cavity here, and then the yolk sac below it. And this is the embryonic disc, which is the embryo, and then have this heart tube forming over here. And then within the heart tube, you have these islands, blood islands that are forming, and these are going to form blood vessels and cells. And they kind of form a horse-shaped tube. And there's another picture of it. These cells form blood islands. They increase in size and number, and eventually they have a lumen or an opening, and they form a plexus of blood vessels. And from this plexus, bilateral endocardial tubes develop. So we get these double tubes forming here. And the endocardial tubes eventually unite to form a common tube, which is the primitive heart tube. And then by day 21 to 22, the single heart tube begins to beat. So here's a picture of the heart tube, and you can see the heart tube continues to elongate, and the cells are added to the cranial end of the tube up here. This process is important for the development of the right ventricle, the conus, cordis, and the truncus arteriosus. And then this length is also necessary for looping. If the lengthening doesn't occur, then you get outflow defects, double alveolar right ventricle, VSD, tetralogy of Fallot, pulmonary artery stenosis, pulmonary atresia. So you can see the various parts of the heart tube. This is important to note, all these different parts. The sinus venosus becomes the veins that enter the heart. You have the atrium here, you have the ventricle, and then the bulbus cordis, which is the outflow tract, and then the truncus arteriosus, which becomes the aorta and the pulmonary artery. So here's a picture of the heart tube here, and right next to the heart tube, we're getting this development of an aorta. The blood islands appear inferior to the endocardial tubes and eventually give rise to the distal aorta right over here. And this becomes the arterial end of the heart. And then at the other end, we get the veins, the vitelline veins, which connect to the sinus venosus and establish the venous part. We're going to talk about that a little bit more next week. So again, we have the heart tube, we have the sinus venosus, where the venous connection occurs, the atrioventricular sulcus, which is where the valves form eventually between the aorta and the ventricle. Between the atrium and the ventricle. You have the ventricle, you have the bulbus cordis, the development of the aorta, and then the dorsal aorta over here. So the next major step is the folding of the heart tube. And this leads to the formation of the bulboventricular loop. Because the two ends of the heart are fixed, the heart tube, as it stretches, is forced to bend in order to make room to the pericardial space. So the heart stretches. As it stretches, it forms the atrium move upward and next to the aorta, and eventually form on either side of the truncus arteriosus. So this is the truncus arteriosus, and this develops, right here is the truncus arteriosus, and then it separates into the pulmonary artery and the aorta, and you end up with the right atrium, left atrium, and then the two ventricles over here. But it's the pushing up of the atrium which causes this bulboventricular loop to occur and allows for the movement of the atrium above the ventricles. Here's another picture now. The atrioventricular junction remains narrow. That's where the mitral and aortic valves and mitral and tricuspid valves are going to form. The AV canal forms the communication between the atrium and the primitive ventricle. So there's one opening between the atrium and the ventricles. And the ventricle also dilates, and the junction of the ventricle and the bulbus cordis remains narrow, and that's called the intraventricular foramen. So that's going to develop into, that's where the ventricular septum is going to form. at the intraventricular foramen. So you can see here the atrium, they call it the auricle here, is moving up. The two auricles here, or atrium, and then the ventricle, single ventricle here, and then there's a intraventricular foramen that occurs to kind of delineate between the right and left atrium, which hasn't really septated yet. Okay, so let's see what we got here. We have the atrium at the top. We have the truncus arteriosus, which is one big vessel, which is going to septate into the pulmonary artery and the aorta. The right ventricle here, future left ventricle here, but they're all connected. And here's this intraventricular sulcus that's going to form between the two ventricles. It's a little bit better than the previous picture. So as the heart is folding like this, also what develops is these trabeculations on the ventricle, and these trabeculations are important because they eventually lead to valves, chordae tendineae, papillary muscle, and the atrioventricular valves. So just so you have an idea, this is where they originate here, from these trabeculations. So about week 4, the sinus venosus gets its blood from the right and left sinus horns. Each horn receives blood from 3 veins, so you need to know this: vitelline vein, the umbilical vein, and the common cardinal vein. And the communication, you can see the 3 veins down here: cardinal vein, vitelline vein, and the umbilical vein down here. And that's same on each side. There's 2 horns. There's the right and left horns of the sinus venosus. There's a big opening between the atrium, and eventually the blood is going to flow to the right, and that occurs in about 4 to 5 weeks. So eventually all the blood flow is going to end up coming into here, and this is going to disappear. So the next major step after the folding is cardiac septation, and this occurs simultaneously in the atrium and the ventricle. So we call it chamberization of the ventricles, or separation into two heart chambers, right and left. The AV canal, which is the area between the atrium and the ventricle, divides into a right and left AV valve orifice, and this comes from the endocardial cushions. And if they don't form correctly, then you get an AV canal defect. It used to be called endocardial cushion defect. It's the same thing, but there's various degrees of AV canal defect. There's partial, total. And so these endocardial cushions are very important for the development of the valves. You can see the cushions here, and they form towards each other, and then they separate the right and left ventricle, and then they also form the valves. So the ventricular septum grows up from the muscular ridge at the bottom. So it grows up from the apex of the heart to the base of the heart. From here, this is the base of the heart, your right ventricle, left ventricle, and the intraventricular septum. The muscular part grows up from here. The membranous part, which is the top portion, grows down from the aorta. So intraventricular foramen is the space above the membranous septum. So that's the septum, and at the top is the membranous septum at the top. And the one at the bottom is the let's say this is the endocardial cushion. These are the valves. This is the endocardial cushion forming the valves between the atrium and the ventricle right here. And this is a hole below the valves and above the valves. And when you have a AV canal defect, you have a ventricular septum and or an atrial septum, depending on the type of defect. So this is showing you AV canal right here. So if the muscular, this is the membranous portion, the muscular, okay, this is the muscular portion coming up here, closing the ventricular septal defect. This is where the muscular portion of the defect originates from, between the right and left ventricles. And it grows up, and then if it stops here, then you have a defect underneath the valve, which is called the AV canal. So the atrial septation is pretty complicated. The paired atria fuse together to form a common atrium. We have a common atrium. Then the atrium septation occurs simultaneously and in cooperation with ventricular septation, and it takes about 10 days. So the septum primum grows downward from the roof of the common atrium. Apoptosis of a small superior portion of the septum primum occurs during continued downward growth, resulting in a foramen secundum. So we have this separate opening down here, it's called a foramen secundum. And then after fusing, the endocardial defect is closed from the foramen secundum, and it ends up with like a flap valve over the foramen secundum. So the septum secundum goes downward, covering the foramen secundum, and then the septum secundum then goes further down and creates a foramen ovale. The two septa together act as a valve to allow blood to enter the left atrium via the foramen ovale and then the septum secundum. So it allows blood to go across during fetal circulation. Then once the baby is born and pressure on the left side is greater than the right side, it closes this flap valve of the foramen ovale. So here's another drawing of the closure of the atrium. You have the septum primum up here, and then the septum secundum goes down over it, and then we get this foramen ovale forming in the septum secundum, which allows blood to go up and through the into the left atrium. So it's kind of like a flap valve that stays open. About 25% of adults actually have a septum secundum that can reverse if the pressure in the left ventricle goes below pressure in the right atrium. So if you do ventricular assist and you put a cannula in the left atrium and you create low pressures in the left atrium, in about 25% of people you can draw venous blood across, and that would be bad if you had done left heart assist, because then you'll be pumping venous blood into the aorta. So it's really important when you do left heart assist to make sure that the surgeon checks for a patent foramen ovale and sews it closed before he does left heart assist, or she does left heart assist. Anyway, the septum primum, septum secundum, and the foramen ovale are all components of the atrial septum. And they repair the atrial defects. There's three, you're going to learn about three ASDs. You have the septum secundum ASD, or you have the septum primum ASD, which is further down in the septum, and then you have the sinus venosus ASD, which is higher up in the septum. So by about the fifth week, you start to get ridges appearing in the truncus, and these ridges develop eventually into a wall that will separate the aorta and the pulmonary artery. These, we call them cushions, grow towards the aortic sac and twist around each other and eventually fuse to form the aortopulmonary septum. And this divides the truncus into the aortic and pulmonary channels. Now the atrioventricular valves also develop around day 55. You can see the atrioventricular valves kind of hanging off the muscular portion of the ventricle, and then they're connected with papillary muscles by the chordae tendineae, and they end up developing from the endocardial cushions. So just to review what we talked about today, we have day 6, fetal development. The embryo attaches to the uterus, embedded in the uterus, the heart begins to form and pump, the aorta and veins begin to form, the heart starts folding, we get cardiac septation, aortic arch starts to develop, and then 5 to 10 weeks is when the exposure is critical because it affects the organs that are forming. I'm going to play this video from this website. All right, I can't play it from here. I'm going to have to do it. You're going to have to go online and go to this tachycardia website to see it. Okay, so normally when I have a class in person, I usually review what we talked about today. And what we talked about mostly was the development of the cardiac, formation of the heart, development of the heart, and septation, folding, the heart tube. Those are the critical components of cardiac embryology. Next week we'll talk about the veins and the aorta, aortic arch, how they develop, and how it pertains to perfusion practice.